And we are right at 9 o'clock, so I'm going to go ahead and introduce our Dr. Beaman, who is the chair of psychiatry at OSU Center for Health Sciences. And I first met Dr. Beaman a couple of years ago when he helped our team at Divis navigate some pretty complex issues. And he is an expert on multiple topics. And we're really, really honored to have him with us, spending the next hour or so. And there will be time for questions at the end. So I'm going to go ahead and turn it over to you, Dr. Beaman.
All right, fantastic. Thank you. And thank you all so much for giving up a little bit of your time to let me share some information on an incredibly important topic. And, you know, I want to start off by saying I live my life in the addiction world and more from a public health perspective. And every road I go down is really, how do we treat addiction once we find it? And it's kind of like trying to take water out of the ocean. And at some point, we've got to start thinking, how do we turn the faucet off? And every time I start to think about that, I keep going back to the same place. The faucet is our youth, specifically our high-risk youth. And so anything we can do to really intercept on that, in that developing brain before those habits are cemented permanently in you know, the cerebral cortex, then we will all be much better off. So I really do appreciate all the work that you guys do. And hopefully today I'll be able to share a little bit of insight. So if you will give me a second here, I will share my screen. Go away. There we go. All right, and hopefully you can all see that. And so we're just going to talk about opioids today. And we are going to talk about the history of opioid epidemics, kind of some facts and statistics around the current epidemic, and then what's going on in response. What are we doing specifically here in Oklahoma to kind of fight it? So first of all, we have to establish common terminology. And basically, you can frame it as there's this flower called the opium poppy flower. And this is an absolutely beautiful flower. Depending on where it's grown in the world, it has these vibrant colors from deep purples to bright orange. Absolutely beautiful. We have a lot of different poppy flowers, and there's one genus that actually has opium in it. And you see it on your screen here. It's got this curved bulb to it. And what you would do is if you had a big farm, and I want you to think of like, you know, hundreds of acres, and you'd have these flowers. And when the bulb happens, when it comes out like that, you would take a curved blade and you would gently cut into this bulb. You don't want to cut it off. You want to cut into it, and it weeps. It weeps just like a maple tree weeps sap. The opium poppy weeps opium. Okay, so opium is kind of like a catch-all phrase. And you can think of it like a bowl of candy or like a bowl of M&Ms. And I can't draw the chemical structure for opium because it is mixed up with a lot of different chemicals like codeine and morphine. So like the green M&M and the red M&M and the yellow M&M. And so for thousands of years, we have used opium and have smoked it, have consumed it orally. Often it would be put into your gums and absorbed in a lot of different ways. So there are different opioids that come from opium. And so if it comes from opium, it's called an opiate. If it works on the opioid receptor in your brain, it's called an opioid. All right, so that's kind of confusing. So I'll give you my rule of thumb. You're always right to say opioids. Everything we talk about is an opioid. You're sometimes right if you say opiate. So I just try to avoid the word opiate. And where are they grown? Where does opium come from? Well, here's a graph that shows that. And you see by far it's Afghanistan. That this is one of the most prolific exports from the country of Afghanistan. And it's getting higher and higher every year, but by a lot, it's Afghanistan. And then you have, and almost all of this is illicit. There are 6 countries around the world that can grow opium legally for medications. Afghanistan's not one of them. And so all of this is being trafficked to Russia or to Iran, where it is then sent around the world. We have some historical places that have always made a little bit of opium, like Myanmar, which was really big in the 1970s, and then Mexico, which is becoming more important as the cartels try to diversify their portfolio, because for decades, the cartels have lived off of marijuana revenue. And then legalization of marijuana has kind of taken that out of their monopoly. And so now they're looking to diversify in heroin and methamphetamine. So we've seen pretty dramatic changes in those. Well, so I said that you could grow it legally. And one of those places is right here on your screen. And this is an island off the coast of Australia called Tasmania. And you know the place that has the little devils? And this is a farm called Tasmanian Alkaloids, or this would be similar to the farm of Tasmanian Alkaloids that until 2016 was owned by Johnson & Johnson. And that's important because the state of Oklahoma sued Johnson & Johnson, and Johnson & Johnson was like, what? We didn't do anything. Well, 80% of the opium that was used to make opioid medications in the United States came from Tasmanian alkaloids. Or as I like to think of it, 80% of the dead bodies on autopsy tables had, with prescription medications, had the opioid-based product from Johnson & Johnson. I like to say that if Johnson & Johnson were a baseball team, they'd be the New York Yankees. Sorry if you're a Yankees fan. All right, so that's where opium is made. And then why do we have it? Well, for thousands of years, we have known that opium was medicinal, and I absolutely won't deny that. We can cut you open and do surgery on you by giving you an opioid and blocking that opioid receptor. Absolutely medicinal and has very valuable medicinal qualities in certain circumstances. But in the same amount of time, we have known that opioids and opium can be recreationally used and has addictive properties. And so when you think of opioid-based medications, you need to think that it comes from opium. And while people may say, well, you can't get addicted if it's a medication, I always fight back and say, well, you're using the same flower that makes heroin. So why do you think you can't get addicted? And basically it's opium and one chemical step, you get morphine. And then with morphine, one chemical step, you get heroin. So why do we think people can't get addicted to oxycodone and hydrocodone if it's for pain? What if you had pain and I gave you heroin? Would you get addicted? Sure, you could get addicted. So we are in the middle of our third opioid epidemic in the United States. And the first one happened because we had some precipitous events happen in the 1800s. The first is, for the first time, we were able to go into that candy bowl and take out just the red M&Ms and concentrate them. And that's by getting morphine. So we were able to extract morphine out of opium, and now we had a very concentrated opioid-based product. And around the same time at the Civil War, so we were using morphine orally. And that's how you got it. And people were getting addicted. And doctors around the end of the Civil War said, you know what the problem is that people are consuming this by mouth. If we could inject the morphine directly into their veins, they would not get addicted. So that's why we invented the hypodermic needle. turns out that was a horrible idea. And people got very addicted very quickly because now we had a concentrated opioid product that could have rapid delivery to the brain. And so in the mid 1800s, opioid addiction was known as soldier's disease because we had all of these wounded Civil War veterans that were treating their psychological pain with opioids. And really, we kicked off a horrible opioid epidemic. Well, then in 1874, St. Mary's Hospital in London, that's the same hospital that about 40 years later would discover penicillin, a pharmacist kind of monkeying around trying to find this golden myth of a non-addictive opioid discovered heroin. And he wrote a paper and he put it on the shelf, and nobody did anything with heroin until Bayer Pharmaceuticals, the same people that brought you aspirin, marketed heroin as a cough suppressant. And they did that for about 10 years, like, hey, this is great for your cough. And they realized it was really, really addicting. And so then they stopped it. And so since about 1920, all heroin use, most heroin use around the world has been illicit. Well, so in Oklahoma, we were hit by the first opioid epidemic. And here is some language from the Daily Oklahoman talking about a town hall meeting in August of 1919, which is really funny because I spent the month of August of 2019, exactly 100 years later, every Friday night in August, I had a town hall meeting in different places in Oklahoma, from Tahlequah to Lawton and McAllister and Ardmore. And it's like 100 years later, we're having almost the exact same discussion with the same people. That the narcotic situation, or now we would say the opioid epidemic, is so serious it demands the immediate attention of citizens. And then the mayor of Oklahoma City said he saw a pattern of drug addicts being arrested and placed in city jail, fined and released, the revolving door that we see with drug addiction. And he was pleading with citizens to contribute money to help fund treatment, which is the same discussion that we're having now. We need treatment, not incarceration. So in the first opioid epidemic by 1900, we had 250,000 opioid addicted individuals throughout the United States. And one of the responses was to create morphine maintenance clinics. And we did that in 44 cities. And what you would do is you'd go to your doctor and you'd get like a little kit of morphine, and you'd go home and you'd inject it over the next like 4 days, and then you'd go back and get more. And then anytime you have overuse of a substance or a substance that's causing any kind of problems in society, you're going to have regulation. Like the sun comes up in the morning and goes down in the evening, you're going to have regulation. And so the government got involved and said, well, the first thing is we got to stop smoking opium. That opium dens and having opium as a recreational drug is gone. So since 1909, that has been illegal in the United States, but also kind of like what we're seeing with marijuana now, often in drug policy, before it becomes a federal law, most states issue kind of their own version, and then the government comes in and makes it national, even though all states were already doing it. And so by the time we banned opium, it had already been made illegal in most of the states, starting as early as San Francisco in 1887. And then in 1914, we had the Harrison Narcotics Tax Act, which made it illegal for doctors to prescribe medication, to prescribe opioids to treat opioid addiction, which is a concept known as harm reduction. That, look, I get that you're addicted, and I'm really worried about you buying heroin on the street or pills on the street that we don't even know what they are, and you're having to steal to get it. If I could just prescribe it to you, like, we'll have better outcomes. And the government said, no more of that, no more of this morphine maintenance clinic or anything like that. And that is still true today, that as a doctor, I cannot prescribe an opioid for opioid addiction unless it has an FDA indication for that. And there are 3: naltrexone, methadone, and buprenorphine, which is commonly marketed as Suboxone. If I do that, then it's, if I give like oxycodone, like I know you're buying it on the street, I don't want you to get in trouble, so here's a prescription for your addiction, then I would be in big trouble. Now, I can prescribe methadone all the day long for pain with no more regulation or burden than prescribing any other medication. So if it's for pain, I can give any dose, any amount I want. But if it's for opioid addiction, then you can only get methadone in a methadone clinic. And buprenorphine, you can only get for opioid addiction if that provider has completed a class and done registration and all that. So when it was made illegal, doctors started to get prosecuted. And so the 1920s, we saw thousands of doctors around the United States get prosecuted. And so what do you think happened to opioid prescriptions? They nosedived. It was very hard from 1930 to 1996 to get opioid for chronic pain. You could get it for acute pain or cancer pain, but outside of that, we didn't. Well, in the middle of that, we had the second opioid epidemic, which was soldiers returning from Vietnam. In Southeast Asia, they had been exposed to opium and also heroin. They brought those cravings back. And we had a little blip of a heroin epidemic, mostly on the East Coast and in Boston, Baltimore, New York City, and then on the West Coast with LA and San Francisco. It was during this epidemic that we realized methadone, actually, if we give you a dose of methadone a day, you don't overdose, so you don't die, you don't go to jail, you don't go to prison, you don't lose your job, you don't get divorced. You actually have a pretty normal life. You just need a pill once a day. Okay, so then the current epidemic. Well, the 1980s saw two simultaneous events, and you can see a lot of common patterns happening with the different opioid epidemics. And I can already tell you now, like what the fourth opioid epidemic is going to be. Well, so the third one started in the 1980s with two kind of simultaneous events. First is medicine was evolving, and doctors were doing things to patients that we had never done before. We were doing new types of surgeries. We were doing chemotherapy, and we were asking patients to live with conditions that they previously would have died from. And we were asking them to live with very painful conditions. And so out of that grew the very honest and well-meaning, legitimate physician-led movement of hospice and palliative care with pain management, led by some really well-meaning cancer doctors and whatnot. And at the same time, the drug companies, big pharma, were discovering new narcotics. And what do you do when you have a new narcotic? You have to get it into as many patients as possible. And we've seen that over and over again with big pharma, that they don't really care about who gets it. They just want as many people as possible to get it. And there's always this kind of fight to get as many indications as possible, to extend it into new populations and whatnot. And, you know, market, like kind of hinting that it's off label. We saw that with different antipsychotics when they were released. Well, opioids are no different. And the drug companies realize that if you're only treating cancer pain, and I want you to think of this from a business perspective for a second, it costs, like, let's say $10 of advertising and marketing to get one patient prescribed an opioid. And you might, on that one cancer patient, make $1,000 off of them before what? Before they die. Well, that's not a good business model if you're always spending money and you have high turnover in patients. And so the drug company said, we've got to get this out of the cancer patients. We've got to get it into the everyday person. And that's where they hijacked the well-meaning physician movement and really started to hammer this concept of chronic pain. We didn't have chronic pain before 1996. We had multiple sclerosis, we had rheumatoid arthritis, we had the conditions, but now I have patients come to me and say, I'm on opioids, and I say, okay, well, why are you on opioids? Well, I got chronic pain syndrome. I say, okay, where's your pain? Everywhere. Okay, well, what causes it? Everything. Okay, and there are conditions that have people where they do feel amplified pain signals, but opioids are absolutely inappropriate for those patients. So we really started to have this vague chronic pain syndrome, which we did not have before the big bad pharmaceutical companies took over. So one of the things that they really hit on was that you can't get addicted to an opioid if you're using it for pain. All right. Now let me flip that up a little bit and tell you, they were telling us you cannot get addicted to heroin if the person had pain. Okay. So if you stub your big toe, right, which we've all done, and that is painful, right? No doubt. And if you stub your toe and you're hurting, if I give you heroin right then, you won't get addicted. That something magic happens to the brain when you're in pain and you can't get addicted. Well, that's just ridiculous. But they use some kind of shady science to demonstrate that. And one of the things that they used is this paragraph, right? It's like 13 lines. You can ignore the entire rest of this page, and it's this paragraph. And this was written by Jane Porter and Herschel Jick. We call it Porter and Jick. And this paragraph is a 1981 letter to the editor in the New England Journal of Medicine. And what they did was they looked at patients that had been admitted to the medical hospital, okay, so like St. Francis, St. John's, OSU Medical Center, Hillcrest, for any reason, and they got a few doses of an opioid. How many of them got addicted? Turns out very few, okay? And I would agree with that, that if you have a medical problem, you get a few doses of morphine, you're probably not gonna get addicted. That's all it says, and it's a letter to the editor. Well, since it came out in 1981 until 2017, this is also from the New England Journal of Medicine, the dark green represents the number of times that it was in the published medical literature citing Porter and Jick, not as a letter to the editor, not as a few doses, but as basically saying you cannot get addicted to an opioid if you have pain. All right, so doctors were reading this hundreds of times in the medical literature, in major medical journals. So I don't think doctors ever did anything other than, now we've had some bad apples out there, and I'm going to talk about a few, but doctors really, for the most part, only did what they thought was best for their patient. And they were being told, hey, look, science has said you can't get addicted if you're using it for pain. That's the gimmick. And so when we have the fourth opioid epidemic, like 100 years from now, hand to God, it's going to be because the pharmaceutical companies have come up with some sort of gimmick. And it's going to take us 30 years to realize, wait, people are dying. And they're going to, they're going to say that there's a pain epidemic or a cough epidemic or a stubbing your big toe epidemic, and we've got the solution. So they're going to sell us the problem, and then they're going to sell us the solution. And people are going to die if it's anything that works on the opioid receptor without having some different property to block that addiction potential. So we saw aggressive marketing by Big Pharma, and they really hit doctors hard and said that we were bad people if we weren't doing, if we weren't giving our patients opioids. Well, doctors were not only reading this in the literature, but they were regulated to death by things like pain is the fifth vital sign. So this article right here is from the Journal of the American Medical Association. New England Journal is the #1 medical journal in the world. JAMA is #2. And so this is in JAMA, and you see right here that it's written by the American Pain Society. Remember them, because they're going to come up in a little bit. I'm going to blow this up here for you. This came out in 1996. And there's a line there that says, the data can be recorded on a vital sign sheet at the patient's bedside. Okay, this is where pain is the fifth vital sign came from. Now, what are the other vital signs? Blood pressure. I use a machine, I get a number. Temperature. I use a machine, I get a number. Heart rate. I use a machine, I get a number. How do we measure pain? Smiley faces. On a scale of super smiley to super frowny, how bad is your pain, right? And the regulation said hospitals could lose reimbursement. They could be in violation or sanctioned if a patient had a smiley face of like orange, dark orange or above, and they did not get aggressive treatment, which they listed as opioids. All right, so think about that. Now, starting in 2002, anytime you went to the hospital, you had to be asked about your pain. You went into the hospital for a cough. How's your pain? You went into the hospital for throwing up. How's your pain? And if it was like 6 or above, you got an opioid. So people often ask me, what does it take to get addicted? And there's only one answer to that question. Okay, it does not matter what your childhood was. Doesn't matter about peer pressure. All of that stuff doesn't get you addicted. What gets you addicted? Exposing the brain to an addictive substance. Because I don't care what your childhood was like. I don't care how bad your dad or your mom was. If you never have alcohol, you have 0% chance of being an alcoholic. Can't happen. Can't happen. There are very few certainties that I have in medicine. That's one of them. Okay. So here are people that had unexposed brains that we were exposing. Okay. And I think it's very important for youth because they got exposed in certain ways. And there are basically 3 big ways people got introduced into opioids in the medical arena. And number 1 is a high school athlete with a sports injury. I'm a football player on a Friday night and I get a back injury. And I go to my hometown doctor and I get 30 days worth of opioids, right? Where I'm taking it 3 to 4 times a day. I am soaking my brain in opioids. Like, what do we think is going to happen? You know, what do we think is going to happen with that? The second way is C-sections, right? And you have a C-section, you get 30 days. And often with the refill. So now we got 60 days of a young mother that is descending into addiction at the same time we need her to attach and form bonds. And then the third way is dental procedures, all right? Dental procedures that you go in for a simple tooth extraction or something like that, and you'd walk out with really high MME for 30 to 60 days. So, you know, we were flooding the market with these opioids. We had the consensus statement, and doesn't this look official? Doesn't this look, you know, super scientific? And I would believe this if I were a doctor. And came from our friends, again, at the American Pain Society. And then here is one of the first times you see chronic pain. Again, this came out in 1997. And here they say studies indicate that the de novo or new development of addiction when opioids are used for the relief of pain is low. Studies show. And I'm a doctor and I'm reading this. I'm like, well, studies show that you can't get addicted. And if you go to this consensus statement and you look for the studies, what are they citing? Porter and Jick. So they say studies. They don't say letters to the editor indicate, or one paragraph indicates, or patients that got a few doses of opioids indicate. They say studies. Well, my goodness, I have not read all the studies that these smart people have, so they must know what they're doing. Well, so let's look a little bit more at pharmaceutical influence into the organizations that might treat this. So here's our friends right here at the American Pain Society. In a 4-year period, well after the height of pharmaceutical company shenanigans, the American Pain Society got almost $1 million from Big Pharma, including Janssen, who is now owned by that evil empire of Johnson & Johnson. And so $1 million may not seem like a lot, but my question to you would be, for what? For what? Well, you read this and you don't know that this is funded by Big Pharma. Okay, you think that these are independent, ethical medical organizations. You don't know that they're being paid millions of dollars by Big Pharma to write what Big Pharma wants them to write. Okay, so that's what the money's going towards. So by the way, American Pain Society is now defunct and bankrupt and being sued for all of this nonsense. Some other organizations, there's one, I can't remember what it is, but it's just a post office box in New York City, and the chairman of the board of that organization is the head attorney for Johnson & Johnson. You can tell I don't think very highly of Johnson & Johnson. And so they made this COVID-19 vaccine, and they're going to save so many lives. Well, I hope they save more lives with their vaccines than the number of people that they've killed in the opioid epidemic. Okay. Now, also in the opioid lawsuit, we kept referring to Johnson & Johnson as a family company, that they're peddling all of this horrible drugs, but they're a family company. It turns out a family company is SC Johnson. Okay, they make like cleaning products and stuff. And we know that because SC Johnson sent us a cease and desist letter telling us, stop using our slogan in your trial because you're giving us a bad name. Johnson & Johnson has never held themselves out as a family company, but they do hold themselves out as like a legitimate, like we try to help people. Okay, so what happened as a consequence to this, aggressive marketing campaign? Well, look at opioid prescriptions. They skyrocketed. In 1996 is when we had the consensus, or 1997 is when the consensus statement came out. And look what happened as a result of that. And by 2010 was the height of the national opioid prescription epidemic. Oklahoma hit our peak around 2012. And this is OxyContin. Oklahoma has always preferred hydrocodone. And for most years since the mid-1980s, hydrocodone has been the #1 prescribed pill in Oklahoma. Well, let's look at the opioid epidemic in real time. So here you have opioid overdoses in dark red. Dark red is bad, and that's people dying of a drug overdose. And purple not so bad, and blue down here in like South Texas, and kind of in the Northeast is good. That's what we want. And so you see in 2003, Appalachia was already cooking, and you see San Francisco. Let's look at the United States in 2017. Look how many counties had turned dark red, okay? You see on our legend here that dark red is 20 per 100,000. And to put that in perspective, the suicide rate is the top 10 leading cause of death in the United States at a rate of about 12 per 100,000. So 20 per 100,000. In some of these counties in Appalachia, like Cable County, West Virginia, has a rate, I think, of like over 50 per 100,000. I mean, it's just mind-boggling. And look at what happened to Oklahoma. All right, so in 2003, Tulsa County, this was right when I was beginning my medical training, and we started to really see a lot of pill mills and bad doctors. But overall, Oklahoma, not bad. And you see really kind of concentrated in Southeast Oklahoma. I'm from McCurtain County. I'm surprised it's not orange, but you see it kind of consolidated there. Well, let's look at Oklahoma in 2017. All right. These pills like have devastated our state, and the numbers have only gotten worse since 2017. Where do they get them from? Most people are getting them free from a friend or relative, and most of those people get them from one doctor. We talk a little bit about young adults. NISDA, which is the drug use survey, showed that Oklahomans aged 18 to 25, so that transitional age youth, exceed the national average with opioid use disorder. And if we look at data from 2017, 2018, 82% of people, youth surveyed, perceive the greatest risk of harm from trying heroin once or twice. So that's really, really good in that they see really high harm in heroin. And I think we would all agree, like, man, heroin sounds bad. And when I think of heroin, I think of like a back alley behind, a seedy looking gas station. Even though that's not what it is at all anymore. We want people with all drugs, we want them to perceive it as bad. And that's been one of the alarming trends in marijuana is that, the risk perception among youth has just dwindled. And now that it's pharmacies and all of that, it's on every street corner, we just see that people really don't see any harm in marijuana. Well, only 8.45%, a little over, about 8.5% of people surveyed reported misuse of pain relievers. So not super high in this age group, but still almost 1 in 10. 1 in 10 misuse pain relievers. Think about how many people are getting pain relievers. Golly, that's a lot of people. Okay, so here's the prevalence of different substance use disorders in Oklahoma, aged 18 to 25. So illicit drug use would be like not a prescription. It's about 8%. Pain reliever use disorder, actually having this diagnosis is very low. And there's a lot of reasons we believe that that's not accurate. The statistical methodology for a state like Oklahoma just doesn't work out very well. Alcohol use disorder in this group, 10%. Wow. So we do spend a lot of time talking about opioids, and I could give you nightmares talking about the methamphetamine problem that we're experiencing right now. But I do have to hit home that our number one problem for over 100 years and for the next 100 years is alcohol, alcohol, alcohol. Alcohol ruins more lives in Oklahoma than any other substance. And then if you look at any substance use disorder, about 15% in this age group. If you look at a metric of the opioid epidemic, you can look at the number of prescriptions per 100 people. So if we had 100 people on the Zoom call right now, how many bottles would we have? Not pills, but bottles would we have? And I've got the numbers from 2007 over here. And in 2007, in Pittsburgh County, we had 205 prescriptions for every 100 people in that county. Like, I had to double check that. I can't believe that. That's enough for everybody in the county to have 2 prescriptions. Holy moly. And I got the top 10 counties listed there. Tulsa County came in at 154. And then I got 2018 numbers. They just released 2019 numbers. And in that, Tulsa County, I think, is number 1 at about 160. No, actually, Harmon County is still number 1 at 164. And then Tulsa County, Oklahoma County are 2 and 3. But we're still at like 174. And even the recent numbers are, we're still well over 100 prescriptions for 100 people in the county. Oh my goodness. That is terrifying. Well, so as a result, in 2008, we saw something remarkable happen. In 2008, you were more likely to die of a drug overdose in the United States than from a motor vehicle accident or a firearm. And I want you to think about that for a second. What is the purpose of a firearm? It's to hurt, right? Now, I know we use it for hunting, but hypothetically, it is used self-defense or whatever. The purpose of a firearm is to hurt. What's the purpose of a medication? It's to help. What is wrong with the world when you are more likely to die from something you get from a physician than you are from a firearm? And in cars, right? We've made vehicles much more safer. We've tightened regulation. You got to wear your seatbelt now. We have little alarms that go off if you're not wearing your seatbelt. What have we done to addictive medications? We've made them incredibly more unsafe. So there are 3 waves of the opioid epidemic, and I'm going to kind of speed through the rest of my slides so I leave time for questions. But we transitioned in 2010 to heroin. We're seeing a lot of heroin in Tulsa right now, way more than we did 10 years ago. And now we're starting to see a lot of the fentanyl. So what is the response to the epidemic? Well, now we have a lot more regulation on opioids that you can't get more than a 7-day supply in the beginning. And doctors have to check in with you so often and whatnot. A lot more tracking of the poisons that the pharmaceutical companies are bringing into our state, because in the opioid lawsuit, one of the big problems was we didn't know we couldn't find out how much they'd actually sold. Well, now that is registered with the Oklahoma Bureau of Narcotics. House Bill 2798 created the Opioid Overdose Fatality Review Board, where a lot of stakeholders and state agencies once a quarter get together and review all opioid overdoses that occurred in Oklahoma. I am the chair of that board, and that is a very sombering event. And we try to identify themes and things that we can do different to try and save lives. We came out with the CDC guidelines that really come up with good kind of operating instructions for physicians on prescribing opioids. And if you are someone who prescribes opioids, I would highly encourage you to review those. And we are seeing a lot more MAT and really buprenorphine. And as clinicians, we have to be recommending methadone and buprenorphine to our opioid addicted patients. That your chance of dying is 6-fold higher if you're not on opioid-based treatment compared to 0.8 higher if you are. Okay, so why do we give methadone to people? Is it replacing a drug for a drug? Sure it is, but it keeps people alive. And as a doctor, my enemy is death. So I will do whatever it takes to fight off death. And if you're alive, I have a chance of helping you. If you're dead, I've got 0 chance of improving your life. There's been a lot of lawsuits, including we sued Purdue, and through a very kind of a tricky set of circumstances, we were able to get a settlement from them with $200 million going to the entity that I'm with at OSU, the National Center for Wellness and Recovery. And we were able to get that money literally about 30 days before Purdue declared bankruptcy. And so right now we're one of the only states to get any money out of Purdue. Johnson & Johnson really dug in their heels and said that they had, excuse me, that they had nothing to do with it. Like, what? Me? What? I was at a barbecue. And so we sued them and we said, you are horrible people. You're a horrible company. And a judge agreed. And this happened in Norman, Oklahoma, and they were ordered to pay $500 million. And that has been appealed. We're hoping for, we wanted $17 billion. We're hoping now for around $5 billion. And to put that in context, the tobacco settlement when we sued Big Tobacco was about $1 billion. So we're thinking about 5 times more. That Johnson & Johnson's poison has cost the state of Oklahoma and will continue to cost us billions of dollars. And so this will probably be appealed up to the US Supreme Court, and we should have some resolution sometime soon. We also got money out of Indo Pharmaceuticals and Teva Pharmaceuticals. You're going to see doctors being arrested like Dr. Nichols, who prescribed more than 1,800 opioid pills in the month of their deaths. Now, if I want a patient to take a medicine once a day, I give them 30 days. Twice a day, it's 60. 3 times a day, it's 90. 4 times a day, it's 120. 60 times a day, you have to take the medication to get a prescription with 1,800. These are all allegations. She has not been convicted yet. At OSU, we've launched Project Echo, and if you have anything to do with addiction, I highly encourage you to come to our Project Echo. Basically, it is a Zoom call, and we were doing Zoom before it was cool, before anyone knew what it was. And once a week, we have a team of experts sit in front of a Zoom panel, and any clinician, therapist, nurse practitioner, PA, physician, LCSW, anybody that is not a patient can come to this conference and get a little bit of education and then present us a case of someone that's addicted, and we'll tell you exactly what to do. Happens every Monday at noon. We also have a Psychiatry Echo Thursdays at noon if you want mental health education and consultation. Well, we created the National Center for Wellness and Recovery. We are now partnering up with community mental health centers and FQHCs around the state of Oklahoma to make addiction treatment available to anybody without regards on how they're going to pay and without the need to travel. We also have a freestanding addiction medicine clinic here at OSU. We are researching the root causes of addiction and pain. I provide a lot of education like this on opioids and addiction and pain and all of that. We do have a 5-day addiction medicine conference in the fall, open to all types of providers, hitting different like addiction in the law, addiction in Native America. I highly encourage you to look for that. And then we work tirelessly to eliminate the stigma of mental health and addiction through policy advocacy. Like this afternoon, I'll be presenting to the Attorney General and the Opioid Commission, helping them understand how we need telemedicine parity and loosened regulation on telemedicine so we can help our patients where they live instead of kind of forcing people who don't really have cars, who don't have the infrastructure in place to drive 2 hours to see an addiction doctor, to help them get treatment. With that, I will open it up to questions. Any questions you guys may have, feel free to just unmute yourself if you're able or put it in the chat.
I had a question.
Sure.
I work at Laureate and I'm an intake counselor, and it just appears that there's not enough places where people can detox. Like they're struggling with mental health, but they're also struggling with addiction. Our facility is not really geared towards helping people detox. And when we send them to somewhere like 12 and 12, there's a waiting list. And when somebody's ready to detox, you can't really schedule that. When they're ready, you kind of just got to get them in. And it just seems like there's not enough places for people to detox medically before they can get mental health.
Yes, I would agree with you, but also I think the concept of detox is a red herring in opioid addiction treatment. Now, alcohol, completely different. But in opioid addiction treatment, you don't really need to detox. You need to transition to buprenorphine. And that can be done in any clinic where the prescriber can prescribe buprenorphine. And we've got plenty of open spots in our clinic. So if they go to your place and now if they're coming to Laureate and they need inpatient psych treatment, you can send them to outpatient detox, but you can treat their opioid addiction and get them onto buprenorphine at Laureate. I know that they do that quite often. And then you can just transition them to an outpatient provider like Family and Children's Services, OSU, CTI, once they get out of Laureate. So we don't ever want to detox somebody unless we have what's next. Cold turkey and detox without treatment is just almost guaranteeing an overdose death. So be very, very cautious and just say, you know, shake it off. I'm going to lock you in a room with a Gatorade and a smile, which is what we used to do 10 years ago. And I know when I did part of my residency training at Laureate, we would do cold turkey and kind of detox all the time. We know now that that detox and cold turkey just kills people. So if they come and you feel like they need inpatient, then you can do a transition in a medication-assisted detox in Laureate, or you can, if they're outpatient worthy, you can send them to like Family and Children's OSU, or 12 and 12 also has ambulatory detox that is getting kind of more and more ramped up. So they may have more capacity for that in the near future. I got a question from Cassie, who says, what is my opinion about people trading addictions with MAT? Again, like if it keeps you alive, I don't care, right? I don't care if it keeps you alive and not getting HIV and hepatitis C and you can keep your job. Now, buprenorphine works, methadone is trading one opioid for another. Buprenorphine, you can't really get high from. Now, that's not a challenge, right? You can get high from anything. You can get high from water if you drink enough of it, but from buprenorphine, you can't really get high from it. And if it's mixed with naloxone, which is called Suboxone, you can't inject it and get high. So I feel like we're going to do way more good with medication-assisted treatment than without it. Okay, got another question. What about our youth that are approaching the age of 18 where they will be treated as an adult and tons of treatment are offered. What is available for those that feel they don't have a problem and clearly heading down the wrong road? Yeah, and I mean, that's the biggest challenge, and I see that all the time. Motivational interviewing, non-confrontational therapeutic approach, outlining the pros and cons. So what are the benefits of opioid use, and what are the good that you're getting from that? Okay, can you identify any bad things that opioid use is causing in your life? And just kind of constantly engaging them without like preaching at them. Demetrix says, very good information. Thank you. I appreciate that. According to the research, more youth and young adults are experiencing non-fatal overdoses with opioids or prescription medication rather than fatal overdoses. Could this be due to their age and their body's ability to detoxify the prescription, and also due to the use of naloxone in Oklahoma? Well, first of all, I will tell you that the Department of Mental Health and Substance Abuse Services, way back before it was cool, like we're saying 08 and 09, they were very, very aggressive in naloxone. And I think that Oklahoma has always had a mismatch in in overdoses with prescribing. Right now, we're probably the #1 state in the country for opioid prescriptions per 100 people, but we're not the #1 state for overdoses, and we've never been. And I think that's because ODMHSAS really, really was super aggressive on naloxone early on and save lives. So I don't know that it's the young body's ability to metabolize, because when you're talking about opioids, it's not really youth-related metabolism, and although it could be, I think it's probably due to what they're using. That we know that heroin and fentanyl are more likely to cause overdoses, and you're not more likely to use those in that early age, 18 to 20-year-old. The average heroin user in Oklahoma right now, I think, is around 28, but don't quote me on that. Antoinette is saying, can you tell us more about the consequences of fentanyl in Oklahoma? Yeah, it's death and destruction and everything in between. Fentanyl is an absolutely horribly dangerous drug, and it is out there being sold as oxycodone or hydrocodone. And so people are injecting fentanyl and not knowing it, and it's just like horrible. And I'll tell you that AG Hunter is looking at really closely with the fentanyl overdoses and going to the drug dealers and saying, if you're going to kill people with this, I'm going to put you in prison. Jerry's asking, where is the money from the lawsuits being allocated? It seems Oklahoma's in great need of more dual diagnostic term long-term treatment programs at low or no cost. So there was an abatement plan that was presented. It was crafted through input through people like myself and ODMHSAS. And that abatement plan is part of the Johnson & Johnson money. And Johnson & Johnson money, and it will be allocated to the medical examiner's office, who has had dramatic increase in workload and expenses because of the overdoses. Law enforcement, Department of Corrections. A very sizable treatment portion of that abatement plan, of that billions of dollars, is geared towards treatment, low cost or no cost treatment. So once that comes out, it will absolutely be going. Now, also some of that TEVA money is going towards treatment. ODMH is piloting opioid treatment in jails, starting with the Tulsa County Jail. So we're very, very hopeful of that. So it's getting out there. OSU is using its money, like I said, to provide treatment at no cost to FQHCs and community mental health centers, so people can go to that. So it really is starting to funnel out there, so people can get it without worry about cost. Okay. Tiffany says she works at an MAT clinic, and most of her patients have goals of tapering off Suboxone. This is the #1 question I get, or probably number 2. Number 1 is marijuana. Like, what do I think about marijuana? Can I just save you the time and say I don't like it and leave it at that? Do you have any examples of good collaborative titration plans, and do you observe? So as a general rule, we do not recommend tapering off of Suboxone. Patients do have that goal, and I recommend it after like 2 to 5 years, but we don't recommend people taper off insulin. We don't recommend people taper off their heart medication, their cholesterol medication. Bad things happen when they taper off. You got a super stable patient where everything good is going on in their life. We don't want them to taper off. And so you can have withdrawal if they taper off, and you can have relapse. If you're going to do it, I would do it incredibly slow, incredibly slow. I'm getting a direct question here that I think is really important, and I want to address it. What is my opinion of harm reduction efforts being made in Tulsa, such as needle exchange? And you guys may be aware that needle exchange has now made it out of the Senate. There's 2 bills, and we are very, very close. We were so close last year until COVID wrecked it. I am a big fan of it. I'm a big fan of it. Why? Because I don't think anyone should get HIV. I don't think anyone should get hepatitis C. I don't, okay? And I get that the paternalistic person in me can say, hey, listen, if you don't want HIV, don't use drugs, right? But first of all, there's a way to be a human. And you have to realize that I treat addiction all day long. And I treat people that are like, pouring the wine bottle in their mouth while they're crying. Like, I don't like it. Like, I'm miserable right now. Please help me stop. So this concept that we can say, hey, you don't want HIV, stop using drugs. It's just like, that's not based in science. People use drugs because they're addicted. And there's a compassionate way to treat them. And we can do that through harm reduction. And we can, again, my goal is to treat them, and I can treat them. Recovery is possible. When I talk about addiction, the word that comes to mind is hope. And I'm always so hopeful that I can get people into incredible recovery stories. And if you want a great example of recovery, go to Women in Recovery's website and look at what they've done to those women. I mean, that's our goal. That's what we should be doing with all addiction treatment. And if I can prevent them from getting HIV in the meantime before I can treat them, then absolutely. Also, with any harm reduction program, we're always going to be engaging in case management and trying to get them into treatment. So I am a big fan. I'm one of the advocates. I've been working with the bill language and working with legislators, trying to get them to understand this. And from our legislature, it's just pure fiscal sense that the money it's going to cost to treat patients in Oklahoma who will end up on the public health dollars because addiction, by the nature of the illness, you don't have insurance. They'll end up just taking state dollars in one way or another. So, save us money and let's keep them from getting the disease in the first place. So big fan, big fan. I do have a hard stop at 10 o'clock. So I want to thank you all very, very, very much for your time and attention and all the work you do in all the different settings. I want to thank Dejan for the opportunity to come and speak to you and arrange this.